So thank you so much for this invitation to present today. It's truly an honour to be here presenting in front of you all. And my goal today was to really sort of touch back on some old principles, see how new data continues to reinforce those old principles, and then maybe move our needle a little bit further forward as we start to think about combining those with new approaches to be able to really improve neurological outcomes in the NICU. And although my objective said we would focus on the term and the preterm, I'm really going to start with the preterm infant because, as many of you know, there is still a major issue that faces us in terms of the neurodevelopmental challenges that the preterm infant faces around motor deficits, around cognitive and language deficits, and an increasing recognition of behavioural problems, particularly in the domains of attention and anxiety. We can ask the question, as has been asked, have these outcomes improved? Because if we are making an impact on the type of care we are delivering, we would hope to see that steadily we are improving outcomes. And this is data that comes from the Australasian group, led predominantly by Lex Doyle, with cohorts that have been studied in Victoria on a systematic basis over these time periods that are reported here. These are 8-year-old outcomes, and they're reported from 3 cohorts that were recruited in 1991, 1997, and 2005 are the 3 cohorts. And here are the outcomes at 8 years for cognitive domains, so IQ, reading, spelling, and math. And these are the percentage of the children who at 8 years are scoring with a Z-score of more than 2 standard deviations below the expected. So you can see when you look at this, even just for these domains alone, it's not reassuring that we are improving outcomes. Motor impairments, you can see again that if anything, a slight rise, particularly in the non-cerebral palsy type of motor impairment, the clumsiness, the developmental coordination disorders, whereas cerebral palsy, whoops, we lost it. Cerebral palsy has been relatively static. There we go. Executive functioning is also important and has been looked at consecutively in these cohorts. And you can see here again, if anything, as we look at the different performance indices, whether that be global executive composite, behavioural regulation, or metacognition, that the number of children who have elevated...
Hi, this is Kelly with neurosurgery at UVA.
Hi,
I was just calling to make sure that the COVID test was scheduled.
I think we may have someone whose mic is still on.
Terrie, we're not seeing your slides.
Oh, okay. Let me go back to trying again.
I wonder if someone else is sharing their screen. It says Barbara Stone Street on the...
Let me try this one more time. Yes, hang on, there's somebody stopped sharing. Open share tray. And try this. Can you see slides now?
There you go.
Great. Okay.
Yes.
Thank you so much for pointing that out, Barbara. I really appreciate it. So let me pop through and see, as you can see here, the long-term outcomes that we recognise in terms of motor, educational challenges and behavioural challenges. And here is the data that you couldn't see from the 3 cohort periods in relationship to outcomes for cognitive and motor outcomes across 3 cohorts from the early 90s to the early 2000s, really unable to reassure us about improvements that may have been occurring in our neonatal outcomes. The same can be seen here for executive functioning, which also may be worse in this more recent cohorts. And this is also a concern that has been raised internationally. So in terms of reinforcing the old, what types of causes could we be thinking of for these adverse neurodevelopmental outcomes? And have we been making any inroads in terms of reducing these types of adverse factors that may be leading to some of these neurodevelopmental outcomes. Let's look at brain injury, and to start with, let's focus on intraventricular hemorrhage. So this is data that was available to us from the Vermont-Oxford network data, recording data on around 55,000 preterm infants here. You can see over an almost 10-year period. And this is all grades of IVH shown in the left, occurring in around 25% of infants less than 1,500 grams. And you can see the distributions here for grade 1, 2, 3, and 4. I think it's pretty clear from this data that at least over this decade, we have made no particular impact in reducing the rates of intraventricular hemorrhage, and particularly notable is reducing the rates of the severe intraventricular hemorrhage. This was also shown beautifully by the Neonatal Research Network in their beautiful publication, looking at data on close to 35,000 infants less than 28 weeks gestation. And although they showed over a 2-decade period an improvement in survival, they showed really that there was no significant reduction really in the rates, particularly of severe intracranial hemorrhage, despite the fact that antenatal steroids had increased significantly and there were fewer infants that were being intubated for respiratory care. So if we're going to make an impact on intraventricular hemorrhage, which we do not appear to have done, despite everything we have been trying for the last few decades, what do we have to bear in mind? And it's pretty clear that for intraventricular hemorrhage, there are factors we cannot influence easily that may be recognizable risk factors, such as the degree of immaturity of the infant or the environment from which they've come that may have been influenced by chorioamnionitis or by perinatal compromise at the time of delivery, leading to the need for the resuscitation and low APGAR scores. However, there are things that occur, particularly in the first 72 hours, within cardiorespiratory and metabolic domains that we may be able to control if we had better data. So why have IVH rates not declined? We know that there are factors, and we'll talk a little more about these, that reduce risk. Antenatal steroids do lead to maturational advancement of the germinal matrix, which should stabilize that for less likelihood of hemorrhage. There are definitely more cesarean section deliveries of these extremely preterm infants. Surfactant, we know, reduces the risk of pneumothorax, and prior to the 1990s, pneumothorax was one of the key factors associated with the risk for intraventricular hemorrhage. There is less ventilation and less suctioning, less handling. We try to position the head and delayed cord clamping. However, we are dealing with more immature infants. We know surfactant has a very dramatic effect on cardiorespiratory physiology, which may result in cerebral steal, particularly in some infants. We know we are using more PEEP, and this may be impacting cerebral venous drainage, which we have only more recently started to study. We are using more opiates, which may affect autoregulation. And there are other factors that we still really don't understand what to do with, such as our friend, the patent ductus arteriosus. So when we think about vascular factors in particular, these seem to be very key to the etiology of intraventricular hemorrhage. And no one has pointed this out more pertinently to us than Joe Volpe over the last 6 editions of his landmark textbook. There are many factors that will affect cerebral blood flow, including its fluctuations, increases in the cerebral blood flow itself, increases in venous pressure, decreases in the cerebral blood flow, which I think when I was training, we spent most of our time talking about, and platelet and coagulation disturbances. So if we look at some of these, as is shown by neuroinfrared, one of the constructs that has been present for nearly 20 years has been that of the concerns about the lack of the ability to autoregulate the cerebral circulation in response to systemic changes in blood pressure in the preterm infant. And as you can see here on the top panel is a graph that shows changes in the mean arterial blood pressure, shown in the red, that are being matched almost identically by changes in cerebral oxygenation shown in the blue, so-called complete loss of cerebral autoregulation, such that every change that occurs in the systemic circulation is mirrored in the cerebral circulation. In contrast, you can see in the more stable graph below that despite some changes which are less significant in the mean arterial blood pressure, that the cerebral oxygenation stays relatively static. There are many factors that influence cerebral autoregulation, particularly that of perinatal asphyxia in the preterm infant, which we are still not very good at defining. We're not good at recognizing it in the term infant in terms of encephalopathy, and in the preterm, we're actually pretty hopeless. So how can we do a better job of recognizing which infants may have had perinatal compromise prior to delivery or around the time of delivery? Ventilation, particularly CO2, is known to be a potent regulator of cerebral autoregulation. Anemia, sodium intake, and the impact of opiates is unknown, but it is hypothesized because the vessels are laden with these mu receptors, particularly in the cerebellum, that this may be another predisposition for changes in PaCO2. The duct is still a bit of a dilemma for many in terms of when and what to do with the duct. But you can see here in this depiction here, the mean arterial pressure is pretty stable and pretty adequate. And however, there was concern over a patent ductus arteriosus here due to a very loud murmur, and treatment was commenced. And after the treatment was commenced with indomethacin, there was an improvement in cerebral circulation in terms of the cerebral oxygenation that was measured. We know that one of the most important factors is this relationship between low flow followed by high flow. And we are still, I think, understanding how much of this is truly causative or how much of it is associated with the occurrence.
No, yes. So you now in Cincinnati, will you be seeing patients?
I think so.
Yes. So you need to build on that confidence.
Somebody needs to mute.
I think there may be somebody who needs to mute.
Sorry.
So this is an elegant study that was carried out where, and the elegant studies that are really now done are really trying to combine measures of cardiovascular output alongside those measures.
We can't see your slides, Terrie.
Sorry?
We can't see your slides.
Huh. Someone must.
I'm seeing them very well, Terrie.
I can see them.
We can see.
We can see them.
I see them very well.
Yeah, they're fine.
Yeah, we can see. I think please go ahead.
Okay, I will keep going. I'm sorry for all these technical challenges. So I think we have still work to do, but the most elegant studies now are really being able to capture what is going on within the cardiovascular system alongside what is going on in the cerebrovascular system. So we can really understand what's driving blood pressure changes and the impact this may be having on cerebrovascular perfusion. We know there are also factors that elevate arterial blood pressure, and in particular in the past, these included pain, handling, suctioning, systemic complications such as pneumothorax or rapid volume expansion, and the occurrence of seizures. This beautiful study that was carried out at WashU by Zachary Vasulius looked at an extraordinarily large number of preterm infants and their measurements. These infants, as you can see, had a mean gestational age of 25 weeks, and you can see the distribution of inotrope use and how many of them suffered from high-grade hemorrhage. What you can see here is the graph on the left, figure 1, which you can see in the dark lines represent those infants that had severe IVH, and that initially their blood pressures tended to be a little bit lower, but at around 40 hours you can see the switch, and then they become a little bit higher than those infants without IVH. And look at how broad the band is compared to the infants without IVH. Now, the exact timing of the injury to the germinal matrix and the hemorrhage is always difficult and challenging to exactly time. But it was clear from this data that infants with severe IVH spent significantly more time with extreme arterial blood pressures, that of below 23 or above 46, compared to those without severe IVH. And indeed, in this beautiful article, Zach really puts forward the hypothesis that this mean arterial blood pressure equal to gestation is really not probably the best guide, but really we need to be keeping our blood pressures above 23. However, one does need to think about what is happening here during this period. Is it, again, causative? Is this an over-response, or is this the causative component for the time of the rupture of the germinal matrix? We know that cerebral venous congestion is now also being increasingly recognised as an important factor in intraventricular hemorrhage. Factors including labour and delivery and impaired venous drainage have previously been recognised, but perhaps not talked about as much. We've known that high intrathoracic pressure caused by pneumothorax was a potent associated factor for IVH. But the effects of these different levels of PEEPs, these different modes of delivery of PEEP, these different methods of ventilation have not truly been studied in terms of what they are doing at all times to cerebrovascular perfusion. On top of that, there has been a lot of data that has been collected over time looking at route of delivery, supporting the fact that caesarean section delivery does appear to be associated with a lower risk of IVH. Here is one piece of data showing how the changes in the airway pressure on an oscillator can alter cerebral saturations. Mean arterial blood pressure unchanged, oxygenation systemically unchanged, but when there was a change and a lowering of the mean airway pressure on the oscillator, you can see the improvement in the cerebral saturations. So for IVH, we still have a ways to go in terms of understanding these contributors to its etiology, but it is pretty clear that the new data around the importance of cerebral vasculature is contributing to reinforce what we knew already. That is, this period of the first 48 to 72 hours of life is critical, that if we're not monitoring, we're really not going to be able to know. And we'll talk about that a little bit further down the talk about why it's so challenging for us to be able to gain access to these technologies. The second thing in terms of modifying neurodevelopmental outcomes in the setting of IVH is managing posthemorrhagic ventricular dilatation. And I point you to this beautiful commentary that was written and led by Mohammed Aldib around guidelines for how to improve outcomes in this condition. And the first of those guidelines relates heavily to the fact that serial and repeated cranial ultrasounds must be done on infants that have the presence of intraventricular blood to be able to define by measurement the size of the ventricles, and then to be able to plot these to be able to improve outcomes. The reason that we think this is important is because of this work, again out of WashU, done with Amit Mathur, where the anterior horn width, the thalamo-occipital distance, the ventricular index, these measures of how big the ventricle was at the time that the infant was in the neonatal intensive care unit were correlated with their outcomes at 18 to 24 months. And what you can clearly see, regardless of the measure that is done and regardless of the outcome, was that the bigger the ventricle, the worse the outcome. And this has certainly been the underpinning across all of the trials that have been carried out, that the bigger the ventricle was allowed to become prior to intervention, then the worse the outcome. And these ventricles are not that big compared to when most in the United States intervene, which on our work and the work of the Neurosurgical Hydrocephalus Network appears to be out here, way out here, compared to the European approach, which is much more in here. So based on that, Mohammed developed these beautiful curves and these intervention approaches that use measurement thresholds by the postmenstrual age for either feeling safe in the green, starting to get a little bit worried in the amber, or being very worried in the red. And these are done for each of the 3 different measurements, which can be plotted based on the serial ultrasounds that are undertaken. Based on those measurements and the zones, you are then given guidelines about how to risk stratify and manage these infants, such that if you come into the yellow zone where your ventricular size is here and you don't have any of these other signs of an acute disorder, then you should be thinking about having your infant in a neurosurgical centre of excellence, considering doing LPs, continuing with regular ultrasounds 2 to 3 times a week, and really starting to have neurosurgical intervention if stabilisation doesn't occur. Of course, because of the high risk that these infants are at, we would always recommend an MRI at term equivalent to fully document the extent of their brain injury. These are much more aggressive and earlier periods of intervention than many in the United States are used to, and we were fortunate to have several neurosurgeons on this commentary to reinforce the collaborative approach that is required in your centre to be able to successfully intervene. And then, as we said, with doing that, successfully drive the ventricles never to become extremely big or distended, and to improve the outcomes by driving the IQs from the 60s into the 80s or 90s. The next area of brain injury that is important is that of cerebellar hemorrhage, which is recognised in around 2 to 8% of preterm infants on ultrasound and more like 15 to 20% on routine MRI studies. And in particular, these smaller cerebellar hemorrhages are often not visible on ultrasound and only visible on MRI. You can see here these smaller types of hemorrhages that are occurring bilaterally here in the hemispheres. This is a larger bilateral hemorrhages. They are most common in the most immature infants and the sickest infants, and they vary in size. But as I've said, the small lesions are really just detectable by MR. They are associated with opiate use, and this may relate to vascular autoregulation being impaired, and particularly in a paper that was published on fentanyl. And larger hemorrhages are clearly associated with cognitive, language, and behavioural abnormalities, so discovery of these is important. Here is the meta-analysis that was published just over a year ago, looking at all published data in association with outcomes by either cognition, showing a 3-fold increased risk, or by motor, showing a 3.6-fold increased risk of disability associated with cerebellar hemorrhage. And finally, the most common area of injury in the preterm infant is that of white matter abnormalities, which are a constellation of terminologies and pathologies ranging from the old-fashioned cystic infarction of all cellular elements to the more white matter punctate lesions, which are presumed to be glial scar in nature, or a atrophy and loss of white matter volume with an ex vacuo ventricular dilatation. You can see here the types of abnormalities that are seen, just very small punctate lesions or more pronounced punctate lesions, particularly in line with the myelination from the posterior limb of the internal capsule, or linear scarring around the posterior ventricle, or cystic abnormalities. So how to improve outcome? What do we do about these brain injuries in our preterm infant? How can we really go about improving the neurodevelopmental outcomes and reducing these risks of injury? To be able to do that, I think there are a couple of key approaches you can be looking at right now in your unit, and there are other key approaches that are coming and we do need to be prepared for and aware. The first is, how are you thinking about your perinatal care bundle, and do you have an IVH prevention bundle within your unit? What kind of brain monitoring do you have available for these preterm infants? And then the awareness of the neurotherapeutic approaches that could be given to these infants and where we're at on those. And finally, realization of the opportunity for neurorehabilitation within your unit. So when one thinks about the optimization of the perinatal factors, this recent beautiful review article looked at all of the data that is published around perinatal factors and delivery room management associated with intraventricular hemorrhage in particular, and showed that there are both factors that have been shown to increase and decrease the risk of intraventricular hemorrhage. The factors that you can particularly make sure you've got a tight coordination with your OB providers obviously still are antenatal glucocorticoids and maternal medications, including tocolytics and antibiotics in the setting of chorioamnionitis. In terms of the delivery room factors, obviously we are cautious about temperature and try and pay careful attention to that. Try and improve the skill of the resuscitation to avoid hypoxemia. Make sure we are acutely aware of signs of any acute perfusion, particularly in the setting of an abruption. Avoid hyper or hypocapnia, and avoid multiple intubation attempts. This has been clearly shown to be associated with an increased risk. Delayed cord clamping has been shown to be overall of benefit, but not in preventing severe IVH, and similarly with cord milking. But being able to monitor each of these practices is important. Finally, a recent article was published from the Dutch group reporting a retrospective cohort compared to a prospective post-intervention cohort for a nursing intervention bundle. This was studied in 561 infants less than 30 weeks, and the intervention consisted of maintaining midline head position, incubator tilt, avoidance of head down and sudden elevation of the legs, particularly during diaper changes, avoiding rapid intravenous or arterial flushes, and rapid arterial withdrawals. So all line care was extremely slow. This was applied directly after birth, starting in the delivery room, and was continued during the first 72 hours during this critical time. And they were all carried out with the exception that a prone position was allowed after the first 72 hours, as long as the head was maintained in the midline. What they showed was that in the prospective cohort, there was a significant reduction in the risk of germinal matrix hemorrhage, cystic PVL, and mortality combined. But the biggest impact was on IVH. And this was the risk reduction here when you included death in terms of the absolute reduction, and if you excluded those infants who then died, you can see even in survivors there was a significant reduction in new or progressive germinal matrix and IVH hemorrhages, really suggesting that something that is implemented in real time right at the bedside may have impact both on arterial perfusion as well as venous drainage in these infants, impacting on this risk of cerebral perfusion changes. How could we also reduce brain injury? Obviously, the holy grail is to be able to monitor cerebral perfusion and oxygenation and oxygen extraction in addition to cerebral autoregulation in real time. Tell us what's really going on that can inform our practices and our care so we know what to do right now for this baby to optimize cerebral blood flow and have ideal extraction. So why has it been so hard to get neonatal NERS monitoring to the bedside for all of our babies? Why has it stayed in the research domain? Again, a beautiful article led by Zach Vasulius really summarized some of the challenges in terms of both the different devices, the different ways they capture, sample, format data, and even the way they interpolate and error correct. All of these things have not been standardized to allow a full translation into the clinical domain. And as we start to translate these into the clinical domain, these are the things we have to think about in terms of how this data is going to be integrated alongside our cardiorespiratory information so that we can really take the multiple tools now that are feeding us information at the bedside to know what to do with this baby right now. Because if you look at some of this data as you come off, again, here is this pattern that has emerged in more than one thing I've presented to you today This is a beautiful Frontiers article from the last 12 months, just looking again at this relationship between echo-driven cardiovascular physiology alongside cerebrovascular physiology, and showing this trend towards those with IVH having these lower saturations, this higher oxygen extraction in this first 30 hours, and then their visibility of the germinal matrix or intraventricular hemorrhage in this window between 30 and 48 hours, when then there wasn't as much difference, before again the fall in the oxygen saturations with the heightened oxygen extraction. So this is a very changing landscape in terms of being able to monitor these continuously being necessary, and being able to extract the data to look at who may be at risk, how can we stabilize autoregulation, how can we provide enough oxygenation and adequate extraction so that the brain can be well perfused and well oxygenated. But we have to think about more than that in terms of what is happening after the injury and what's the downstream effect of these injuries on the rest of brain development. And no one has taught us this more elegantly than Joe Volpe. This is one of his hallmark review articles looking at all of the different regions of the brain that are affected by preterm birth and the downstream and upstream effects of such injuries. And if you just take that vulnerable periventricular white matter with the injury occurring either in the preoglidomeric or the axon, the downstream effects, both in terms of myelination effects subsequently and throughout life, but also effects on both cortical and thalamic neurons. When you start to think about how to protect all these different elements of the immature brain, it becomes really complicated, because what we've been focusing on has been cerebral perfusion, just the hypoxic and ischemic element. And there may be multiple different ways, as we've discussed, monitoring and really being aware and manipulating cerebral perfusion. But when we come to the actual cell types that may be vulnerable to being injured, we also have mechanisms that we can be directly adding protective elements to. Can we be down-regulating microglial activation, inflammation, and excitatory transmission? Can we be preventing some of this free radical generation and providing more defenses against those? Or through multiple different mechanisms giving this type of protection? On top of these acute neuroprotective strategies to prevent things like pre-oligodendroglial death, what other types of restorative interventions could we be doing after injury has already occurred and we need to be rescuing or regenerating in the immature brain? This was also brought out by another beautiful review article that's been published just this year, looking at white matter injury in infants with intraventricular hemorrhage, overlapping the two major forms of brain injury that we have talked about already today. And you can see here, when you start to think about this, there are multiple downstream effects from the presence of just the intraventricular blood in terms of all the different elements that are then activating, as we've said, excitatory, oxidative, and inflammatory mechanisms to lead to apoptotic cell death. And then what elements could be targeted, again, to inflammation, oxidative stress, to reducing glutamate toxicity, or indeed to preventing apoptosis. So you're going to start to see, if we can't prevent the IVH from occurring, can we accurately recognize it? And then which of these mechanisms is going to be the best for us to consider in terms of an acute neuroprotective strategy to these preterm infants? Finally, when we think about neurorestoration and neurorehabilitation, we need to think about directed neurorehabilitative strategies. And unlike pediatric and adult brain injury, where directed neurorehabilitation with physical therapy is common, this has not been our strategy in the NICU traditionally. And part of that has been because we're not quite sure what we should be doing, when we should be doing, how much we should be doing, and whether we know an infant really is at risk of disability in the future. So how do we target that? Or should we just wait until a cerebral palsy is fully established? Most of the interventions that are being looked at are really what we call family focused and infant directed. And most of these studies have really been focused after the NICU discharge. The idea is that we partner with parents to have confidence in both assessment and handling. And this should also apply obviously to staff. And that partnership and coaching of the parents can improve the way they approach all types of motor therapy. The key period that often people are particularly focused on is the first week, 8 weeks after discharge. And do remember that even before COVID, at least in Massachusetts, this is a time where so-called early intervention services are often not very active for our infants. They often may have made one phone call to the family just to see how they're going, but it's not like there is the type of neurorehabilitation that you would get for an adult stroke. For cerebral palsy, there's several key studies that are awaited in higher risk infant groups, such as the term infant, things like the upbeat and the baby constraint-induced movement therapy studies, and these are really aimed to imprint functional neuromotor patterns in the premotor cortex by having the infants watch an action that's being executed when they may not yet have voluntary reaching as part of their environmental exploration. So these types of studies and interventions have been and are being applied at earlier time points in high-risk term-born infants, but have not yet trickled all the way down into our neonatal intensive care unit, into a time period where we may be able to offer something in terms of neurorehabilitation to our infants. Likewise, many of our preterm infants suffer from feeding difficulties, and oral feeding difficulties clearly require intact neurobehavioral development. You need to be able to fully evaluate oromotor skill, aspiration risk, the need for NG or G tubing, and the idea is that really the infant can direct feeding. And we know from a study that was done by Bobby Pineda that the percentage of infants that are getting certain types of speech and language therapy services is actually very high in our neonatal intensive care units. So this is a distinct problem that's associated with neuronal functioning that we don't tend to talk a lot about in terms of outcomes. So when we move on to think about away from the acute injury, what else do we need to be thinking about in terms of our preterm infants to improve outcomes? And it's pretty clear that the brain, as you know, is undergoing an enormous period of growth and development in the neonatal intensive care unit. And you can see from this data that Lillian Matthews published that these are the growth curves, each colour representing one baby for brain tissue over the postmenstrual ages from about 26 weeks to around 43 weeks. And you can see that every baby is slightly different, but there's an enormous amount of brain growth going on here. And that in particular, from about 34, 35 weeks, there's almost an acceleration, a kind of a pivot, where they're growing along at this rate and then they accelerate during that last 4 to 5 weeks. And what are many of our babies doing during that time? They're kind of sitting in the corner, hanging out, not necessarily taking advantage of this brain growth spurt. We know brain growth requires energy and that the human brain has exceedingly high energy demand, about 50% of the total body oxygen consumption, that the brain growth peaks in those weeks that I'm showing you, and that 90% of brain volume accrues from 24 weeks to 2 years, and that we want to provide the metabolic substrates to have good brain growth in the extrauterine environment. So how do we do? Well, we know we don't do very well. And this is data that was collected by Dr. Ehrenkrantz and others looking at the percentage of infants with extrauterine growth retardation, i.e. who became growth restricted after they left the uterus. This is the percentage of infants over a period from 2000 to 2013 who are less than the 10th centile at the time of discharge. Even though it's improved, we're still dealing with well over 50% of our infants who are below the 10th centile for typical term-born infants, and around a third of our infants that are less than the third. We also know that macronutrient content, not just size, matters, and that there's been a number of studies now that have come out looking at both energy content as well as particularly protein content and its impact on both brain size, growth, and maturation, fully supporting and suggesting that the adequacy of nutritional input to permit brain growth in the neonatal intensive care unit is critical during this time period. We can also map brain development looking at the surface of the cortex, and you can see here how much the dramatic changes that have gone on. And many of you have seen me produce this data before, showing that in particular, the region of the temporal lobe along the superior temporal sulcus is particularly vulnerable to deviations by preterm birth. And this is a comparison of 54 preterm infants without significant injury compared to 24 healthy term controls. And this region is by far the most vulnerable to disturbances in development. It doesn't get better with time, and when you image these children at 7 years of age, you can still see this pattern of disturbance in the pretermly born infants compared to healthy term controls. What factors have mediated those alterations? And we and others have shown that experiences appear to be critical, and particularly neonatal stress. It was shown at WashU again by Gillian Smith, now PET, that the amount of painful procedures or the amount of neonatal stressful experiences impacted on frontal and temporal lobe development. It's also been shown by others, particularly this Israeli group, that even an hour of kangaroo care each day for 14 days appears to improve the developmental outcomes both short and long term. And that although some of this is mediated through improved parent-infant interaction, not all of it is. Some of it appears to be a direct positive effect of nurturing. We also know that the room environment is important. And this is a very recent, lovely publication looking at family room environments in the neonatal intensive care unit and outcomes. And this is not focused on neurological outcomes, because indeed, if you look at the intraventricular, periventricular leukomalacia rates, they were no different, if anything, slightly higher in the single family rooms. But other outcomes, particularly length of stay and other types of composite outcomes such as mortality or any morbidity, were improved in the single family room environments. But we know, as we have shown, that there can be a cost, and that indeed in the single family room environments that we studied, we found a selective vulnerability of language in terms of the development of this region in the temporal lobe to the hemispheric asymmetries that you need to develop as a healthy term infant, and that these can be impacted by being in a private room environment. And indeed, a leader in our field by far, Dr. Vore from Brown, who has led much of the insights into the impact of the environment and the impact of the family, has continued to point this out in this very recent editorial about the importance of parent presence and involvement in the single room. And her and I think, are completely aligned. As I wrote a commentary at a similar time, it turns out not where, but who you're with that really matters. So the room is nice, but what really matters is who is in the room and what they're doing in the room. And we really need parents to be present, to be engaged, to be having all of the experiences with their infant that we need. Another study that looked at this was the Canadian-driven trial that looked over Canada and Australasia at the effectiveness of family integrated care in the NICU on infant and parent outcomes. And this was a signed contract, if you like, between the parents and the team, that the parents would be present for at least 6 hours a day, participate in rounds and improve and engage in all cares with their infant. The infants were recruited at a median of approximately 2 weeks of age. So past that first 72 hours of really acute risk for brain injury. And what they showed was, in a similar way to what we saw in our single room, no impact, if anything, a movement towards improved in the standard care, which was not really the time frame that these babies were receiving either of this form of care. But they did show that there was improvement in growth, that the babies gained more weight in the family centered care, and that their discharge appeared to also be facilitated. So how can we improve those kinds of neurodevelopmental outcomes? First of all, we have to acknowledge that the environment influences brain development in many regions, and particularly those regions engaged in auditory, sensory processing and integration, as well as memory. And it's clear that noxious stimuli in each sensory exposure are common: alarm noises, bright light, painful procedures, and that there's an absence often of nurturing and enriching experiences. So again, what can we be doing? This was a beautiful, extensive review that was undertaken and published by Bobby Pineda, looking at all of the different types of interventions that have been tried in the NICU. And it's no surprise, you can look at all of these and see the thousands of studies that have been done looking at different types of things you can do. In particular, I'll just focus on a couple. One was auditory intervention that looked at both live music, or recorded biological sounds. And you can see how short some of these were, 45 seconds or 45 minutes. And they were done 1 to 4 times per day over either 1 to 21 days. And they showed improvement in feeding behaviors, and maternal voice in particular was related to fewer stress responses and better neurobehavior at term and developmental outcomes at 3 and 6 months. There are a number of multimodal approaches using auditory, tactile, vestibular, visual, family nurture intervention, one for hospital to home, touch therapy, kangaroo, and most report a positive impact on both mother and infant outcomes. In fact, as they were summarized here across the different interventions, green represents a positive outcome. And you can see that these are the weeks at which the intervention was done, and the types of outcomes that were measured are numbered. But you can see overall that everything is pretty much green, apart from some studies on kangaroo care where there is an element of red in some studies. But overall, an overall strength of the data to suggest that modifying the environment of these babies in this way improves outcomes. So Bobby has taken this and tried to integrate it into an approach to the NICU sensory experiences called SENSE, a comprehensive approach. Yeah, here is an example of one of these approaches at 23 weeks, talking about touch, hearing, smell, seeing, and movement, and giving guidance to the staff and to the family, because this is an integrated, family-centered, staff-informed approach. And here, as an example, is now 37 weeks, where there is a lot more that can be done around touch or around hearing and around seeing. And so this program is designed to be adjusted each week with the developmental stage of the baby. So if parents are so critical, why are they not there? Why are they not engaged? What is going wrong? We know that when we interviewed a large series of mothers at both the Brigham and the Beth Israel, and this was work that was beautifully led by Leanne Woodward here in Boston, we found that many of our mothers, over 60%, reported some form of psychological distress. And nearly 40% of our fathers, the often completely ignored fathers, also expressed depression, anxiety, or trauma. So being able to have a family mental health program is very important, because you need to be able to understand how you can recognise and engage in a local solution, how you can screen mental health and behavioural health for your families, and normalise that you know that more than half of these families are going to need some sort of support in this domain, because this is extremely stressful and traumatic to be separated from their sick baby. Group therapy with peer-to-peer families is also very powerful. And finally, don't forget ourselves. the caregivers also experience trauma and need a program of care and support for their own health needs. So finally, I know I've focused on the preterm infant, but I want to come back to really think about these domains and these three key epochs. We have a lot of work still to do in brain injury. We are not yet making any inroads into reducing IVH, cerebellar hemorrhage, or white matter injury to be able to improve outcomes. We also are increasingly now becoming aware of the impact of the environment and nutrition on brain development. And finally, we can't forget how critical parent-emotional well-being and rehabilitation, starting, I believe, in the neonatal intensive care unit is. So if we are to make an inroad and improve outcomes, we need to get the brain monitoring tools. We need to support and advocate to technologies to get these into us. We need to be able to understand cerebrovascular physiology and have research groups actively working on continuous cardiovascular and cerebrovascular physiology. And we need to advance and support trials of these neurotherapeutic advances, just as we have for hypothermia in the term infant. How can we support acute care and acute treatments in the setting of IVH? We also need to know that the experiences of our infants matter, and that the technologies we are currently using, the old school incubator we all currently still operate with, has not really progressed in over 100 years. We need to be able to pay attention to whether our parents are present. It's not a nice to have. We should be advocating, even at a political level, for the presence of our parents. And we should be then partnering with them, empowering them, coaching them, having them be the caregivers of our infants. And then we need to understand how to optimize nutrition, and we need to start neurorehabilitation in the NICU. To do these things, there are technologies and things we can drive, as I've said, around bedside monitoring, but also around neuroimaging and the use of neuroimaging. The current guideline that came out recently, unfortunately, really advocated for minimal use of any type of neuroimaging. We certainly won't make any inroads if we never. And then finally, we need to scan our own environments, and we need to stand up and advocate to intervene. What are we doing for our sensory experiences of all of our babies at the moment? What are we doing in regard to nutrition? We now have MIRIS and other tools to be able to quantify on a daily basis what the protein and calorie content is of a mother's individual breast milk, and optimize, not just guess, the content of that. We shouldn't shy away from looking at our babies' brains and understanding where and how they have been altered by the neonatal intensive care experience, and how can we support our parents and educate our staff about the importance of the brain. And I know that's why so many of you have given up your valuable time to be present today to listen to this talk, and I'm sure it has merely raised more questions than provided answers, but I hope it's provided a comprehensive landscape, because I really want us to continue to understand the elements that are going to be critical for us to not be paralysed by, but to embrace, to be able to improve our outcomes for all our infants in the neonatal intensive care unit. And with that, I will thank you for your attention, and particularly your persistence with technological challenges, and open up for any questions.
Thank you. Thank you so much, Dr. Inder. It's a wonderful talk, very enlightening. So there are a few questions I will read from the bottom. This question is about the NIRS. Which group of the babies you are placing NIRS on? What preterm baby groups you are placing, and which day?
Yeah, so we try to place, Mohammed predominantly drives our neuroinfrared program, and we try to place neuroinfrared on all of our babies, certainly less than 28 weeks, and anybody who is sick between 28 and 32 weeks would also be included in that group. And we place it as soon as possible. In fact, we've been very fortunate that 23 of our nurses have identified themselves and have undertaken additional training in neurocritical care. And those nurses really do this. They drive it. The nurses are placing the device on the head, just in the same way they would a saturation probe on the foot or the hand, and have it at the bedside beside all other tools. So we are routinely monitoring them then through the first 72 hours of life, and ideally getting 2 head ultrasounds during that time period.
Wonderful. Do you also do some regional NIRS, like on the abdomen, or just?
Yeah, so when we first started doing NIRS, we did have an abdominal NIRS over the kidney, in particular trying to look at systemic perfusion in the kidney. We actually ran into a couple of our smallest infants having a little bit of pressure-related issues on the abdomen, and so we actually have abandoned doing the systemic measurements because of that, and focused just on the forehead measurements.
Okay, wonderful. Related to the NIRS, do any of the available NIRS technology display trends such as those shown in your presentation?
Yeah, they all display trends. You really have to be aware of how quickly they're sampling and what you're actually seeing. And then you have to be aware in your population what the normative values probably are. Most of the time at the moment, our guidelines are still pretty crude in terms of really having to be very high or very low to be outside, but we personally find the trends over time to be useful. So for us, they have highlighted times when we've seen a trend downwards in our cerebral oxygenation, and at that time, people have checked a blood gas and found that, oh gosh, the CO2 has slipped down, even though the baby would not have been due for a blood gas to have been drawn. Or they've checked if the blood gas was normal, they then would check hematocrit and have seen that the hematocrit has fallen and that the baby may benefit from transfusion. And when transfusion occurs, we've seen the oxygenation go back up. So we have found it to be useful in guiding us, and we have a strategy to act on those values.
Perfect. So regarding the positioning, this question is about how do you balance the IVH prevention measures, such as the midline positioning and the skin-to-skin positioning?
Yeah, so I have to say I am a bit of a believer that these first 3 days probably are the important time to really minimize touch and minimize that sort of handling if possible. And I may be wrong because I don't think we have every baby is so different that we don't have the distinct answer. There is absolutely a way you can take the baby skin to skin and keep the head midline and keep the baby up. And merely having the baby up may be very helpful for cerebral venous drainage versus certainly lying them bang flat rather than the 15 degrees up in the bed. So just having the baby up, skin to skin, having the mother's voice and smell and sound may reduce some of the stresses that may override any of the risk associated with the movement and the potential movement of the head, which may be very brief. Most of the time that we have seen changes in cerebral saturation associated with head position, the head has been to the side for quite some time. So the head has moved to the side. Particularly, I think these are difficult when the baby's on the jet ventilator or the oscillator, when you're dealing with rigid tubing and you're really struggling in terms of positioning all of that equipment without pull or stress or tension. Those are when we start to see the changes. So I think it can be done. But I think overall, this period of the first 48 to 72 hours, when you've got so many changes going on in the cardiovascular and cerebrovascular physiology, may be the time that you want to have as little handling as possible to be able to support these transitional physiologies without any other stresses. Having said that, as I say, I think it's really still to be delineated that it may be reducing the stress so much by having that contact that's an advantage. You've really got to do it, I think, on a case-by-case basis.
All right, great. This question is about the MRI. I think in MRI in preterm infants, what is your opinion, or do you have any guidelines in your unit?
We do. We still do MRI that term equivalent. We are doing a lot of studies at the moment. We have an MRI system in our unit, so we do a lot of studies at the moment related to MR, and we are constantly humbled by babies who wouldn't have even reached our criteria, which are pretty liberal, to get an MRI, who have abnormalities that we visualize. We had a 30-weeker who came recently who had a very small abruption and had a little bit of acidemia, but nothing too dramatic. Had 2 negative ultrasounds, and then got enrolled in one of our studies. We took to the MR and had significant white matter injury with a number of significant punctate lesions and a linear lesion in one hemisphere. That baby would not have been picked up at all and would have been discharged and would have evolved with more significant motor disabilities over time. So being able to inform those parents and get the disability addressed by a level of intervention with our therapy services and with discharge neurorehabilitation is going to be really helpful. So we still image all of our babies less than 30 weeks.
Less than 30. Midterm, great. All right. Do you see any magic bullets in future? Do you see a bullet or bullets?
So I think the problem is everyone looks for the magic bullet. There's no such thing. Okay. You know, I think we are dealing with multiple lesions and we need to understand what we are dealing with. The first is we are dealing with this transitional physiology and risk of ischemic reperfusion injury. And it's a very high risk in that first 72 hours. And we need to have more information on an individual basis. You know, we don't expect to run every ventilator the same way without having the information on sort of systemic oxygenation and CO2s, right? That's what drives and a chest X-ray. That's what drives us to know how we are going to manage an infant's respiratory condition. We're driving it blind for the brain until we have this data on which to operate. So we desperately need this technology to come in. After you get through that first 72 hours, I do believe that if you identify brain injury, because there will be a group of these infants, without doubt, who have intraventricular hemorrhage, even with our best intentions. I do believe that we are going to see a range of neurotherapeutic interventions for brain injury in those infants. And I think the same for the neuroinflammatory conditions, the chorioamnionitis infants, the necrotizing enterocolitis infants, the infants with concurrent septicemia. There will be a series of neuroinflammatory treatments that you will have as an armamentarian, plus minus whether there are stem cell therapies and growth factors. So you will see pharmacological approaches to brain injury, apart from just trying to prevent brain injury from occurring. And these will be evolving, I do believe, over the next 10 years. Had the privilege of consulting for a couple of companies, and they're very, very close to coming out in trial. After that, I think the next big thing I really think we need to be paying attention to is this very prolonged period of brain development. Because after you get out of that first 3 or 4 days, you've got another 10 weeks in your care. And during that 10-week period, we're not paying enough attention at the moment to nutrition. We're not individualizing and knowing what we're feeding our babies in terms of the protein intake every day and how to optimize that. We're not paying attention to the sensory experiences and environment, and we're not engaging our families to be our key partners in providing care for our babies. And I think those are all critical factors in long-term outcomes.
Wonderful. This question is about the blood transfusion. So you mentioned that transfusion would help NIRS. Would you recommend transfusing for less than 30 in the ELBW babies?
So again, I don't think we have I think you need to see what this baby's cerebral saturation level is at this time. And if this baby's cerebral saturation is low and the crit is low, then I would transfuse that baby. If this baby just has a level of 30 and the cerebral saturations look robust and blood pressure is fine, there's no other reason, then there's no reason to have a magic number. It's really about, if a baby in the first 3 days of life has a crit of 30, to me that is low. and that would be transfusible. But if a baby is 8 weeks down the track, then that's a very different matter, and that baby may not require transfusion, of course.
Okay. I think we have a couple more questions. So this is about the developmentally supportive care. Programs like SENSE, is it like they should be widely adapted in NICUs?
So ideally, we would study each of these interventions. As I showed you, there are thousands of studies looking now at all of these individual facets, and you know, it's kind of like, I don't know, how would we put it? You know, if you or I listen to music for 3 minutes going home each night, we might feel a little better. Is it going to make us age better? I don't know, because there are so many other factors, right? And so, you know, we're so naive when we sometimes think, well, I'm going to have this one magic bullet, right? It's going to be the music and it's going to make everything better. When really what we need to always have with any intervention is family-centered, infant-directed, multimodality. But, you know, I will put a plug in again to say that the incubator, let me just draw you a hotel room that I'm going to offer you tonight. I'm going to offer you a really nice hotel room. It's a plastic box with a plastic tray, and I'm going to put a lot of devices on you to monitor you in your plastic tray in your bedroom. Oh, by the way, I'm leaving the lights on in your room, although I might occasionally put a blanket over your plastic room. And there'll be alarm noises going off probably every hour, loudly, in the background, plus a swishing noise inside your plastic box. There'll be a really weird smell in there, and we may or may not have nice, comfy bedding. It'll be variable. And by the way, you will get woken up probably every hour, maybe every couple of hours, but probably every hour, just to make sure everything's okay for you. And that's what your life is going to be like in your new hotel. And, you know, I don't think any of us would want to check into that hotel, right? But we've taken it for granted that this is what we need.
Terrie's talk right now.
So, you know, we need to do a better job of advocating what a developmental environment really should be.
So often, it's so great to see.
So we just need to, we need to be better at advocating. And the same with our parents. I mean, you know, we are not a voice in DC advocating that parents need to be present with their babies, that they are one of the most powerful modifiers of outcome that we could have, that they will provide more breast milk when they're present, they'll provide more auditory input, they'll provide more nurturing, they'll provide better long-term outcomes. And they are more valuable than anything we can buy with our $1 million care we provide. And yet we're not there doing it.
Yeah. All right. Thank you so much. Thank you. I think
I really appreciate you all being present. I appreciate your enthusiasm for babies' brains and improving outcomes. And thank you so much for the privilege of being able to present.
Thank you so much, Dr. Inder, and have a nice weekend. And sorry for the glitches. So stay warm and stay safe. Yeah. Thank you, everybody.
Thank you.
Thank you.